So we are going to talk about carotid artery stenosis. And just for you to remember, we're talking about this area when there is usually a plaque in the carotid artery that causes stenosis, but not just. There are different things that can cause stenosis of the carotid artery that are not atherosclerosis, even though atherosclerosis will be the most common thing you will encounter. For example, fibromuscular dysplasia, radiation, what else? Even Takayasu arteritis. Other things can cause stenosis, but again, atherosclerosis is the main culprit of this disease. So it's based on the Bernoulli equation, and the main thing you need to take out of it is that the fact that as the stenosis is higher degree, the velocity of blood will be higher in the stenotic area. Of course, when there is almost total occlusion, the velocity will fall, and this is a pitfall. Yet, until then, as the artery becomes smaller and smaller, more and more stenotic, the velocities will go up, and we will based on this to define the stenotic grade, the percentage of stenosis based on Doppler for the internal carotid artery. So you can see here the Bernoulli equation and all the things that tell you why. I don't know. So this is the thing we will measure the most, which is peak systolic velocity and end diastolic velocity. We will based on them in defining what is the grade of the stenosis. You will see it in a minute. Now, here you will see the grades based on the velocity. You will see the internal carotid artery peak systolic velocity and end diastolic velocity, but this is the main thing. Peak systolic velocity in centimeter per second will be the definition for stenosis degree. We'll also use the ratio between the internal carotid artery, the common carotid artery, and the end diastolic velocity, which will help us in some cases that are not cut clear, but peak systolic velocity will be the main criteria. You will see that as the velocity gets higher and higher, the stenosis degree will be higher, except for when there is total occlusion or almost total occlusion, where the velocity will drop. Again, this is a pitfall, because you may think there is no occlusion when there is very high occlusion. This is what causes the velocity to drop. You will see that we will start with 125 velocity. We will define the cutoff between normal and not normal, and not normal we define with 50% of stenosis. So you can see that normal is defined as less than 50%, or less than 50% will have almost same velocity as normal, and this is defined as less than 125 centimeters seconds in Doppler in peak systolic velocity. Also, the ratio will be small, and the end diastolic velocity will be less than 40. Now, the next step will be the one that is between 50 to 69 degrees. And you can see the velocity up to 230, because more than 230 will define a more severe stenosis, which is more than 70 degrees. And you can see that with time, the ratio becomes higher and the end diastolic velocity also rises. So the next step will be more than 230 for more than 70% of stenosis, which is considered more critical. You will see in the indication for surgery that this will be in symptomatic patients a more cut clear definition for patients that need intervention, surgical intervention with carotid endarterectomy or carotid artery stenting. Now, the pitfall is with near occlusion, when you may see even variable low or string sign. Anyway, the velocity may drop even though the patient has critical occlusion, that is near total occlusion. Okay, so the algorithm for assessing patients who needs intervention, which type of intervention, So the first idea or the first main takeaway is that we are going to consider all the patients with plaques. I'm not talking about patients with normal vessels without any plaques, not those. I'm talking about patients with plaques, and we just define them based on the degree of stenosis. So all patients should be on best medical therapy, which means high dose of statins to reduce their LDL less than 70, treat their diabetes, cessation of smoking, treat their blood pressure under 140 or 90, and you may give antiplatelets based on your decision. So we divide them to symptomatic and asymptomatic. As you can understand, symptomatic will have much lower threshold for intervention compared to asymptomatic patients. And when we say symptomatic, we usually say that it should have some event, neurological event in the last 6 months, TIA, stroke, amaurosis fungus, something that will tell us that this stenosis may be symptomatic and draw emboli to the brain and cause symptoms to the patient. And asymptomatic, mainly incidental finding in some screening or something. Now you see that 50 to 69% you can consider revascularization. Males are more likely to become symptomatic, but it's very cut clear if the patient has 70% of stenosis. Of course, all of them will get best medical therapy. Now, carotid artery endarterectomy or carotid artery stenting for symptomatic and more than 70% of stenosis. Usually the gold standard is carotid endarterectomy, but carotid artery stenosis may be considered for patients, for example, that are high risk for carotid endarterectomy. Now, for asymptomatic patients, it's based on the fact that less than 60% you won't touch them, namely you give them best medical therapy and leave them alone. Between 60 to more than 80%, somewhere there, let's take the average of more than 70% of stenosis, you will consider in certain types of patients to do a revascularization. And you can see that you need certain type of patient for this more than 70%, those with okay life expectancy, with low risk of surgery, because you are not sure that you will benefit those patients. Compare it to those with stenosis more than 70% symptomatic, you have a number needed to treat of about 6. So it's quite good proportion. Now, what can you choose? You can choose carotid endarterectomy, which is the gold standard surgical intervention, or you can choose stenting for patients with hard neck, distal or proximal lesions, and where the operational risk is too high, something that preclude you from doing carotid endarterectomy. Previous carotid endarterectomy, something that tell you that they are not candidates. So carotid endarterectomy, gold standard, heavy calcification and tuberous anatomy, those are the ones that fit carotid endarterectomy. While stenting, the carotid artery stenting, revascularization. Anyway, stenting is patients that don't really fit carotid artery stenosis. They are too risky for this surgical treatment, so choose this one. And you need to do MRA or CTA for patients that are going to intervention, so that you won't you will see the anatomy and you will see the contralateral occlusion. Now, in terms of complications of intervention, it's important. MI, myocardial infarction, is the most common complication that cause mortality after those procedures. And in terms of morbidity, strokes are the most common cause of morbidity, where stent may have higher risk for this. Now, there are other complications like hyperperfusion syndrome, sorry, which tells you that now you perfuse the brain and you can develop complications like seizures, headache, hemorrhage. So you need to strictly control the blood pressure of the patients before you reperfuse their brain. Nerve damage is another problem in those interventions, especially when talking about carotid endarterectomy. So you have four nerves that mainly can be damaged. Hypoglossal being the most common one, and when there is damage to the hypoglossal nerve, you will see the tongue deviate to the side of the damage. Facial nerve can also be damaged. You will see the mouth just going down, like facialis, but of the mouth because it's the mandibular branch. Vagus nerve, the recurrent laryngeal nerve, can be damaged, so you will hear hoarseness for the patient. And the glossopharyngeal can also be damaged, and then you will encounter dysphagia. So those four nerves, being the hypoglossal most commonly damaged for carotid endarterectomy, are another cause of complication in these surgeries, or mainly in the carotid endarterectomy. So this is it about carotid artery stenosis. Let's just sum it all up. We talked about the hemodynamics, what we measure, PSV and EDV. We talked about the degrees, and we talked about symptomatic versus asymptomatic, and when you consider which intervention. Everyone with plaque should get best medical therapy. Intervention, which types? Stenting vs surgery, and complications that we talk about those from those interventions, especially from carotid endarterectomy. Thank you very much. This is about carotid artery stenosis, and I think this is it for now. That's it.